understood what is community-acquired pneumonia. You understood what is community-acquired pneumonia, how it looks, what is happening. The meat of the issue is how you treat this thing. How you treat this thing. I mean. So if I would ask Kanchan, what would be your treatment for severe community-acquired pneumonia? So you have a patient. You did mention about the fact that how are you going to decide this patient is going to come to the ICU or not? How are you going to decide this? So you don't use the curve 65. Okay, curve 65. Why don't you use it? Because you mentioned during your talk that curve 65 is used as a mortality score. You mentioned that. You mentioned that curve 65 is used as a mortality score. You said confusion, respiratory, blood pressure, BP less than 90, 65 years more, whatever, and you find that this mortality is higher. That doesn't tell you disposition of the ICU. Means where this patient goes. But is this patient going to go to the ICU? Is this patient going to go home? Or is this patient going to go to the ward? When the patient comes to the ER, you have to decide that, right? You cannot just say, "Kidhar bhi rakho, main dekhunga kya karna." So you have to put him somewhere. So what do you decide for that? No, what do you use for that? ATS. This is what you mentioned, right? You mentioned the ATS. Okay, you mentioned the ATS. What does the ATS say? The ATS say two obvious things. What are the two obvious things? The two obvious things say if this patient is mechanically ventilated or on vasopressor, you can't keep the patient anywhere. It has to be the ICU. That is the first thing that ATS said. What does the ATS say? If you are on mechanical ventilation or if you are on vasopressor support, it is obvious you can't keep this patient in the ward. That is very logical. So you can remember it for lifetime. If I issue the mechanical ventilation, you don't have to remember it. Tomorrow when somebody asks you which patient should go to the ICU, you should try to elucidate that the ATS criteria told us that if the patient has got mechanical ventilation or vasopressor support, this patient needs to come to the ICU. Apart from that, among the rest of the 6-7 things that they actually mentioned, they need 3 more things to be there. That's what he mentioned. They need just 3 more things to tell you that this patient needs to go to the ICU. It's where respiratory hair, volume, use of volume resuscitation to get the blood pressure up. These are the 3-4 things you actually mentioned all those things. So, BON and you mentioned all those things. Alright, so out of those 5-6 things, 3 of those things you require, 3 of those vital parameters that she mentioned is required to put this patient into the ICU. Right. Now this patient has come into the ICU. So this is your patient, okay, that has come into the ICU. This is your patient. You need a meet Rashmi. She's the same lady who's coming. Okay, this is the lady who's coming with say a 60-something-year-old lady who basically presents to you with an RR of more than 30. She would have checked us without casualty, found the blood pressure to be 90 systolic, and then you decided, let me give her fluids. You gave her a liter of normal saline, and then subsequently you found the RR to be more than 30. The PON was very high, creatinine was 1.6. So obviously this patient requires the ICU. So you shifted this patient into the ICU. Okay, you have shifted this patient into the ICU. Okay, and now within 3 days, this patient starts worsening. This is what exactly happens. So the question that comes to us is, what do we do? What do we do if we don't know what to do? We actually look into guidelines. What do we do? We all look into guidelines to understand what do we do. We have a good starting point. Now we will understand the guidelines. So, okay, so let us look at the guidelines available. Okay, there are so many guidelines, I don't know what to do with these guidelines. So what we are going to do is, we are going to look at a formula that we are going to use in our ICU. Okay, it is always been that it's a protocol of the ICU. I want to look at a formula that I'm going to do. Okay, and understand this very clearly. But before we go into the formula, the first thing you must understand is there is very high increase rate of hospitalization. In the last couple of years, we have seen very high rates of hospitalization. India contributes to 23% of the severe community-acquired pneumonia that we have in the world. Now, India contributes to 23%. It's a very high number. The whole world, let's say, 1/5 of the cases, almost 1/5 of the cases are coming from India. Okay, that's the amount of contribution that India has. Now, I'm going to show you a graph, a very important graph. On the y-axis, you have the percentage patients that you have. On the x-axis, if you look at the total number of community-acquired pneumonia and the mortality, this is what it is. Say 100% patients. Say someone you have 100% patients. Okay, and then this is your mortality. You put all the community-acquired pneumonia together. Means let it be ICU, let it be ward, let it be sending home. You put all of them together. 20% of those will die. That is 1 in 5 will die. Okay. Now what I do is I take the patients in the ICU. Say this is 100% of the patients in the ICU. Okay. Now 50% of those will die. So now you must understand that I am shifting Lakshmi to the IC, who is going to die 1 and 2 times, 50% chance of death. That's why that shift to the ICU, you must understand it to shift. You can't just shift any other patient, because that is the patient that requires maximum care. That's why we insist on you to understand the ATS criteria. That's why we insist you to understand the ATS criteria, because we know those candidates that actually fulfill the ATS criteria have got a 50% chance of dying because they are severe community acquired pneumonia coming into the ICU. So you must understand this very important. It's very different from the community acquired pneumonia that goes to the ward, or community acquired pneumonia that give azithromycin and keep them at home. It's different, okay? And this, it is not just whatever studies I'm going to show you from now on, it's all going to be from these. They're very small studies. These are the Indian studies that are there. These are all the Indian studies that are there in literature. Okay, this is the total. And if you look at it, the number of studies are very few: 200, 120, 100, 100, 450. The mixing is 453, Chaudhary, and all that has come. Alright. So, what are the common organisms? So that's how you decide empirical antibiotics. How do you decide empirical antibiotics? We're looking at the commonest organisms that are there. The commonest organisms. Otherwise, empirically, I have to decide something. I have to give X, Y, Z. To decide, I'm going to give the penicillin, I'm going to give ceftriaxone, I'm going to give fibracillin, I'm going to give vancomycin, I'm going to give whatever. I have to have an idea what I have to start with. What is the commonest organism that is prevalent is what you must understand. So if you look at this particular studies, what those studies I just now showed is what I put over here. This is I just put in all those numbers over here myself. Okay, when I put those numbers inside, what did I find? That the maximum number is Streptococcus pneumonia. You see there is a big incidence of Streptococcus pneumonia here. Can you see this? 35% is there in almost everything. So what do you understand community acquired pneumonia? The commonest organism that you have to cover, is Strep pneumonia, Streptococcus pneumonia. Here, importantly, what you are also seeing is as we are actually increasing years, we are actually increasing the amount of Klebsiella pneumonia. You understand? So there seems to be a good proportion of Streptococcus pneumonia and Klebsiella pneumonia even in community onset. So I am thinking that this patient may require Streptococcus, will be probably Streptococcus and Klebsiella. And third will come Staph aureus. Now, what did you understand from the previous talk that Niharika did and we discussed over here? This can be picked up on X-ray and ultrasound. So your first empirical antibiotic can actually be thought about very carefully from your X-ray and ultrasound, and you can have an idea that this probably could be Streptococcus, Staph, or it could be Klebsiella pneumonia. Clear? So this is the first thing I'm thinking. I got kind of an idea from at least epidemiology that this is going to be the commonest organism. Right? Now there's another study done 2 years ago. Okay, 2 years ago the study was done. What this person did, now all the studies that I actually made myself, put myself on a table, he has actually done a study on this. 2019, all the papers that we just now mentioned are all Viracharya, Davokar, all the studies are there on this. And he put them all together into this, and he included the studies in a meta-analysis. Okay, he introduced this in a meta-analysis. Okay, and what they found out was, this is the entire pooling of all those cases. 20% of them was Streptococcus pneumonia, like how we discussed. What did we discuss? That Streptococcus pneumonia is maximum. When he found that 19%, actually not 20 in this study, it was 19% that was actually Streptococcus pneumonia. Clear on this? Okay. Importantly, he plotted them on a graph. And on the graph he showed this, that around 19 to 20%, this is 19 now, is Streptococcus pneumonia, followed by Mycoplasma pneumonia, followed by Klebsiella pneumonia. So when you put all the studies together, this is exactly what he found. Very similar to what we found in our earlier. This is what I did. Okay. So here also if you look at it, you had Strep, you had Klebsiella, and then there was Mycoplasma pneumonia that is also there in this nurses. So when you put all of them together, he found that the commonest organisms were Streptococcus pneumonia, Mycoplasma pneumonia, and Klebsiella pneumonia. Simple. So empirically, I must now think, okay, that there is a possibility that I might be dealing with Strep, Klebsiella, or Mycoplasma. This is what I'm going to think in my mind, and then Staph comes after that. Clear on that? Staph and Legionella, right? So now, recently there was the same person, there was another study that was done another 1.5 years ago. What they did, they took the whole Asian population, whole Asian population they took, and they took all the studies from India. We call India, So they took the whole Asian population together, and then they looked at the same empirical antibiotics. They wanted to see what is the usual bug that is there. So what they found again, they did find out that Streptococcus is high. Importantly, you have a resurgence or increase of gram. So in the last 1 or 2 years, there has been an increase in the amount of gram-negative organisms. Okay, Klebsiella is one of those that was there. So if you look at it, 14.3, 2.9, this was outpatient. But if you get severe, if you get sick, what do you get? Gram-negative. So when you are not very sick, that means you are outpatient, that means you are at home. I am probably dealing with Streptococcus pneumonia and no gram-negatives, if you ask. Very poor amount of gram-negatives. But the moment I reach into the ICU or reach into the hospital, I go into the severe category, I am probably dealing with gram-negative infection along with Streptococcus. Streptococcus doesn't reduce, but the gram-negative goes up. So now I have an idea that if my patient comes into the ICU, I probably need to cover gram-negative also. This is coming to my mind. Okay, because this is what we initially showed was all community acquired pneumonia. Now I am going to the category of severe community acquired pneumonia. So when I go into a severe community acquired pneumonia, I am understanding that I need strep cover. I probably need Klebsiella or gram-negative cover, and then I have to think further what should be done. Now this is 2014-15 that is there. Very similar studies are there. 2012, long ago, there was one paper. I took a photograph of the paper at that time. This is to Sarthak Rastogi and Dr. Zari Rudwadia when they were at Puja. They had done this paper. In this paper also I noticed very similar things. What they found was, look at this. Streptococcus pneumonia 23%, severe cap remains almost the same, 26.3%. This is 2012 ERS Society, that is the Congress, they presented a poster, you posted a photo. Okay, and what they found? Pseudomonas aeruginosa, gram-negative, increasing when it becomes severe community pneumonia, very similar to the Klebsiella pneumonia going on. You understand? And the mortality remains high. Mean number of antibiotics, the mean length of hospital stay goes up, and the mortality goes up. So, a study that was done from Mumbai, Hindu Hospital, okay, which actually showed that gram-negative goes up. 2012, much prior to most of these studies that I showed you. Right? So now we have in severe community pneumonia. I explained to you that there is going to be a preponderance of gram-negative bacteria along with the gram-positive, which was not the case. Till now, am I clear till now? Hemant, you understand? Yes. Till now, what have you understood? 2019 तक क्या हुआ है अभी तक?
The incidence of gram-negative is increasing.
Where? In which kind of pneumonia?
In severe community.
That means to say, if my patient is at home, I don't need to rush about and give him gram-negative cover. I may manage with azithromycin, Streptococcus. Are you understanding? The question that I'm having a problem is if it gets severe and if it comes to the ICU, then what am I dealing with? Gram-negative organism. And what is the problem with the gram-negative organism? Very high. So once you go to severe community acquired pneumonia, the mortality becomes very, very high. That's what I showed you in the first graph, if you remember. The first graph I showed 20% and then it becomes 50%. It's very similar to this graph. Very similar to this graph. This is what they have done. Right? Clear on this? Are we clear till now? Now let's go to a study that was done recently. Now AIMS Rishikesh and Guwahati, they had one paper that came out. This is AIMS Rishikesh and Guwahati. Okay, it just came out some 4 or 5 months ago, December, November, somewhere. Here also what you see this blue is Klebsiella. This is severe caps. And when they say severe caps, they're looking at patients with moderate to and severe cap. Good number is there. And when you see that good number, you see Klebsiella to be 33%. You see Streptococcus also to be high. So you have the same pattern. Same pattern that you're seeing right from 2012 till now in 2021. The same pattern. So you must understand from on the background that I'm dealing with strep, I'm dealing with Klebsiella, I'm dealing with staph. This is what I'm looking at. Okay, clear on this? And microplasma follows very closely. So the pattern is now clear in everybody's head. Ki severe community pneumonia agar ho gaya, so this is what I'm looking at. Okay, so this is a cross-sectional study which was done, and it's nice to see a study. These are all patients of curve more than 3 and 5. Okay. So when you look at the resistance pattern, now this is very interesting. Now let's look at the resistance because we have to understand which antibiotic give. Now that we know that this is the bug, we also need to understand what is the antibiotic to be given, because this is severe communicable pneumonia. So let's look at this. Okay. So first important, what is the usual antibiotic we start in the ICU? What is the usual antibiotic? If you have a patient who have come with severe communicable pneumonia in the ICU, what is the usual antibiotic that we start with? In our ICU? Hand up, Hemant?
Piptaz carry through.
Piptaz. So it's not monosef. It's not monosef. It's piptaz. Right. This is what we start. If patient comes with severe communicable pneumonia, we start with piptaz. Now let's look at piptaz. Okay. Let's look at piptaz. This is piptaz. Okay. Look at piptaz. Piperacillin tazobactam. What have we seen? 55% only it is says that 41% is resistant. 1 in 2, it may not work. Are you understanding? You got the point what I'm saying. 1 in 2, it's not going to work. So it's kind of going to be difficult. It's going to be very difficult. Henceforth, it's going to be very difficult because you need to be very certain that this bacteria is working, this is sensitive or not. That is why quickly what you require? Cultures and sensitivities. You require it quickly. It's not like what it was some years ago. कि भाई तुम करो देखते हैं क्या होता है. It has to be done quickly because we need that cultures ASAP. Okay, 1 in 2 is not going to respond to your usual piptaz that you just now started. Are you understanding? This was not the case some 6-7 years ago. This is the case now. Okay. Now look, let's look at gram positive. This is gram positive. You just now said you start azithromycin or clarithromycin along with it. See what happens here for Streptococcus. Again the same problem. The resistance is close to 30 to 40%. 30-20%, 30-20%. You see, for all your usual ones, all your usual antibiotics that you use. So we have a problem. Luckily, what happens is this is not this community acquired strep is not that virulent. Is not that virulent unless it's a young patient who has got very severe manifestation. The co-infections that you have are not very bad. This is gram positive. You understand? They are not very bad. This is a problem for us. Unless it's community acquired Mrsa, this is strep. This is Streptococcus. This is Streptococcus pneumonia. It's not that bad compared to Staph aureus that we talked about, hospital acquired. So now you understand why ultrasound becomes important, why history taking becomes important, why your ultrasound lobar pneumonia it will be satisfactory for you. You understand air bronchogram, see why it is important. You understand? That's why I keep asking you, ultrasound. Why do I ask this? Because I want to understand what is there inside. So is my antibiotic right? Because I know my mortality there. Once the patient comes to severe communicable pneumonia. Now was your understanding? Sound clear on this? Alright. So let's go ahead now. Okay, so this is the same study which actually looks at microbiological profile. What it finds out is severe community acquired pneumonia has resistant gram negatives in a good number. This is what we found. Okay, good resistant gram negatives are there. So gram negatives are quite resistant is what we've understood. And this category of patients that come to our ICU which had actually harbors the resistant ones when they actually figured out the resistant. When they actually figured out that out of that 50%, out of the 100% of patients, 50% were resistant. Right? In that resistant pattern, what was the common feature? In the resistant patients, they found out that they all were having prior respiratory infection, they were having alcoholism, they were having obesity, and their age was more than 60 years. This is what they found. A good majority of numbers with very significant p values that these were the problems that were there. So how important history taking becomes? You see how important it is. If I have a patient who is alcoholic, if I have a patient who is obese, if I have a patient that says 3 months ago I had a respiratory tract infection, what am I dealing with? I'm dealing with resistant gram negatives. That time I'll probably give piptaz. No, I won't. I'll probably give something better. I'll probably give something better than that. You are understanding what I'm saying? You understand what I'm saying? If I'm giving piptaz, even if I want to give piptaz, I say I don't want to give a higher antibiotic. What am I thinking? I need the cultures quickly. So, clear? So this is the data that comes from where? From AIMS Rishikesh, the data that came from Asian population, the data that was I made from all the studies that was there. Then we saw one flowchart with all the Indian studies together. Right? What is our data? That's the next question. हमारे hospital में क्या होता है? You know that's the question. You give me a glass of tea. What is our data? What is our data? That is what you must know. हमारे इसमें क्या होता है? ठीक है इधर उधर इधर उधर इधर उधर. हमारे इधर क्या होता है? That's very important for you to understand. Otherwise, an intensive care population that we are here, tomorrow when doctor, some primary consultant will say, give this antibiotic, you must be able to say, क्या हो रहा है हमारे इधर? हाँ? How will you say हमारे इधर क्या हो रहा है? तुम तो empirical antibiotics दे रहे हो, तुम्हारे पास culture नहीं है, तुम्हारे पास isolate नहीं है, तुम्हारे पास कुछ भी नहीं है. When the first antibiotic is going in, you must be able to say कि क्या देना है. तुम कैसे बोलोगे तुमको क्या देना है जब तुम्हारे पास कुछ आइडिया रहेगा, you have some idea, what is the data? So what is our data? Okay, so what is our data? So this is the data that we have from our hospital. This is coming from 2019. Okay, 2019 का data. Respiratory isolates. These are the respiratory isolates that we have. When I say isolate means हमने उसको pneumonia था, उसको हमने culture किया. Okay. Culture का हमने क्या use therapy में hot coffee. Just tell them outside. This is our gram. These are respiratory isolates. Now we were what did we see in the world? We see in India Streptococcus pneumonia is what we saw as gram positives. Staphylococcus aureus we saw very common. Very similar here also. No? See Streptococcus pneumonia, Streptococcus. That is exactly what we are seeing. We are seeing very similar to what everybody else is seeing. Simple. And 2019, right? Look at this. Okay, these are gram negatives. These are our gram negatives. And this data is something that I keep reading again and again to understand what to do, because at the end of the day I have to tell you what is to be done, and for that I need to understand what's happening here. So what is happening here? Klebsiella, topmost. Then we are seeing some pseudomonas here. You got the point? Very similar to what we had seen in the earlier. It's not different at all. It's really not different. It remains practically the same. Clear on this? Practically it remains the same. There is not much more difference, right? Now let's go ahead. When I actually look at the gram negatives, the gram negatives are more. And why are the gram negatives more? Because I am actually sending this from where? From the ICU. These are our ICU samples. So those patients who are actually community-acquired pneumonia coming to severe cap and not in the wards, coming to the ICUs, at least in our hospital, we've got a good number of gram negatives, right? So there is good gram negative. Now look at the drug sensitivity. So these are the drugs here, and this is the sensitivity. Okay, so if you see Klebsiella, it's only 40. See, the aminoglycosides are much lesser. Look at this. Ciprofloxacin is almost next to not possible. You can't give ciprofloxacin. When you look at cholesterol degacycline, it's near about 90 but not 100. So there also you have a problem here. At 2019 ki baat hai ye. Right? Similarly here also, you have for Pseudomonas a little bit better, not 40. So Klebsiella is more dangerous. Pseudomonas is slightly lesser dangerous, still dangerous 60%. It's around 60%. Where again cholesterol is not 100%, which is disturbing. When cholesterol is not only 100%, it is disturbing. It can be disturbing. If I 100 में से 3 पेशेंट को cholesterol काम नहीं करने वाला, you may tell the patient that I'm going to give you the best possible antibiotic in the world, but it's not going to work. You understand? At least when the lab is not work, this is what we are seeing here. This is the data, right? Now, what I do is I will now show you the same data from gram positive and gram negative isolates. This is 2021. This is 2021. Okay, 2020 का जो data है, I have not looked at this. 2021. Now, 2019 में क्या हो गया हमारा? 2019 में उसके बाद COVID आ गया. COVID आ गया, we were doing a lot of other things. So we had only virus. We had only virus. So whatever we cultured is what this is. Okay, so we cultured lesser, but we found again gram negatives more. This is probably related from COVID. Not related to COVID. But importantly, why I put this slide is to make you understand that हमने cholesterol use नहीं किया. 2019 if you remember, did we have patients on cholesterol? Hardly. Full entire 2019-2020, we had no patient on cholesterol. Our consumption of cholesterol was barely anything. Barely. So what happened actually? Surprisingly, cholesterol became 100% sensitive. Which is surprising for me actually. I am thinking how this occurred. And this is called, what is this called? When you stop using a certain bug, a drug, what is it called as? Anyone? What is it called as? If you stop using a certain bug, a drug, for a period of time, what is it called as? What is it called as in intensive care? If you don't use a certain drug for a while, it is called antibiotic cycling. What is it called? It is known that antibiotic cycling doesn't work. It doesn't change the sensitivity, but we have actually seen cholesterol. I put this slide because I just want to tell people for some reason antibiotic sensitivity was. So 2019 actually was like this. Okay, 2019, and this was the sensitivity pattern that we had. Okay, and what happened in 2019? This is 2019, right? It was sensitivity somewhere around between 20 and 40, 40 and 60. And what happened in 2021? 40 and 60, and higher 60 and 80. Definitely it's improved. That's because of our protocol in our hospital. People stopped using indiscriminate antibiotics. Everyone was just giving remdesivir. We didn't use only antibiotics. You understand? We didn't use. The only place where antibiotics were getting used in the entire setup was where? In the ICU. We were not using it anywhere in the hospital. So it is not obvious. What does it tell you? You don't use unnecessarily antibiotics. Isn't it very clear? It's so clear. It is so clear that if you don't use antibiotics for a while, you see sensitive pattern getting back. You know, it's so nice. I just feel so confident. That's the reason I keep telling you antibiotic de-escalate karna, antibiotic de-escalate karna. You understand why I'm doing that? I'm doing that not because I just feel like stopping the antibiotic. It's because of the fact that when we do it, there is clear cut, at least from my data, showing that there is a definite improvement in resistance. You understand, Mrsa? Huh? Clear? So now, after understanding all this, you've understood what the epidemiology is, you've understood what the resistance patterns are, what is happening, what are the bars. The question is, which empirical antibiotics have you used? That is the exact question that we want to answer after all this. Alright, so there is a whole lot of antibiotics, whole lot of antibiotics. But first, one important tenet that I tell you is, always use one particular antibiotic, which is that which coverage you use maximum. Always and always you will use an atypical coverage. Always. That is very important to use an atypical. Why is that? Why? Anyone? When you say atypical, what are you looking at? Clarithromycin, azithromycin, you know these things. And what am I covering? Mycoplasma, things like that. Atypical. Right? Why? Streptococcus be 20, Streptococcus 30, Streptococcus 28, Mycoplasma 17. Why? Why am I putting this so 100%? कि हर पेज को चालू करना. Any idea?
In atypical we get multiple.
You think atypical is more virulent?
No, but extra.
No. What you're telling me is
extra pulmonary manifestations are more.
So you mean that will be the patient? Because most of our patients in the hospital, in the wards or in the home are actually atypical and step. So घर पे हो. You give azithromycin very often, right? Atypical. But why atypical? It's severe pneumonia. You don't expect mycoplasma to come with hypotension and tachycardia and respiratory distress. You don't expect that. You don't expect that. If they are not that virulent bugs, atypical there. Right? So why do you want to give it? Because there is a significant advantage. I'll show you how. So this is what it is. This is 3 years ago. There have been many data. This I just picked up one data. Now what is it showing? Person in hospital mortality versus disease severity. So I have non-severe and severe diseases. Only this. So what am I saying here? If it is in severe, okay. If I give a macrolide, if I give a macrolide, what is happening? So if it is what is happening over here? Person hospital in-hospital mortality has come down compared to those patients who were not given macrolide. Simple. Single pneumonia mein the mortality is much higher if you don't give a atypical cover. It's as simple as that. And there are many reasons for it. The reasons and so very clearly the advantage is there for a macrolide. Okay, there's clear advantage for a macrolide. Clear, and that's because it's got something like an anti-inflammatory, immunomodulation effect. It's not related to the coverage of mycoplasma. It's not related to the coverage of say another atypical organism. It's because it has got some kind of effect which is related to immunomodulation that actually improves the patient. Clear on that? There are many studies based on this. This is one of the latest that has come out. That's why I put it over there. Right? In fact, there have been so many studies that have come out. This is one of the studies that comes in just 2 months ago. This is 2 months ago. Okay? 2 months ago. What happened in this? This was in Israel. Okay, in Israel they looked at all the patients who were severe community acquired pneumonia. and they put them all together. Some thousands of patients they put together. Okay, in those thousands of patients, also what you see, the mortality with the empirical therapy with macrolides reduced the odds of mortality by 45%, very similar to the graph I showed you. This effect was evident with azithromycin and with roxicomycin. The effect did not require a full course of therapy. Even if you give 3 days of macrolide, we have a significant advantage in terms of mortality. So what is now from this discussion, what have we understood now? We gave an atypical cover. Simple. That's the end story. We give an atypical cover. So that is our first empirical antibiotic. If somebody comes and says, "Arey, you need a mycoplasma hoga," आपको क्या सोचना है? We are not giving for that mycoplasma. What am I giving it for? I am giving it for the mortality to come down from the other effect that comes in from any atypical coverage. Sound clear? Clear on this? Because what will happen is, say first day you send a blood culture, you send a sputum culture, you might get that to be positive with Streptococcus. Some physician might come and tell you, "Chalo, isko band kar do, khali ye rakho." What you have to say, in severe communicable pneumonia, I want to give it not because I am covering strep. I am giving it so that I can have the significant mortality benefit that is supposed to come with macrolides. So, clear on this? And our backbone antibiotic, ये तो अपना empirical cover हो गया ना, उसके ऊपर एक backbone antibiotic डालना पड़ेगा, एक बड़ा antibiotic डालना पड़ेगा इसके पीछे. It has to be a beta lactam. There is nothing else but a beta lactam. That is our workhorse. It has to be a beta lactam, especially because our ICU patients will have all these things. Now, if this patient, now clinical knowledge will come in, saying that if this patient has got septic shock, if this patient has mechanical ventilation, I am going to start thinking about kya hai? Is this probably a resistant organism that is so violent that is causing these many things together? So I will see, or इसको तो RR भी fast है, or इसको तो create already गया हुआ है. I am looking at the severity now myself. Clinically, I am judging what's happening there. Okay, what's happening there, and then I am deciding what I should add over it. Okay, so in that case, depending on the severity, what will be I would add into this piperacillin tazobactam or cefepime tazobactam or etoposide, depending on the severity. So depending on the severity, but what we know, meropenem or piptaz or cefepime still are only 50 to 60% sensitive. They are not 100%. They are not 100%. Clear on that? So that is why what do I require quickly? I require my cultures essentially as soon as possible. If I had all the money in the world, or if this was my relative or one of your relatives, what I would do? If this was my relative, now that you've understood that how difficult it is to get an antibiotic right, it's a matter of luck, and it's a matter of your understanding of the case. So say if someone of my relatives is admitted, what would, or say for example, Ruchika, your relative is admitted, what would you do now? Because starting meropenem or starting cefepime or starting piptaz are still only 50 to 60%. You don't want to start cholesterol directly day one. It doesn't benefit the lung that way. So what do you do? What would you do? Culture will take 3 days, 4 days, 5 days. That's why you will need a rapid diagnosis. Now the rapid diagnosis comes from various methods. What are the methods that you know of? So in biofire, what is there? What is biofire? What is biofire? So we'll put that for another talk. But you need a rapid diagnostic. So there is a certain swab sample that needs to send out this later on. I've done this picture for you. But I'll tell you later on. Okay, about the biofire. But at this moment it's not that we need a rapid diagnosis. The answer we need a rapid diagnosis by a multiplex PCR. Okay, and how, which swab, what culture, where, which nasopharyngeal go through what. It's not just biofire everything. It's not just biofire blood. It's not just biofire sputum. You have to understand what exactly you are saying. And we'll come to that when we actually do biofire. When we do actually rapid diagnosis. That's not the topic for today. But we know that we have to do rapid diagnosis. Rapid diagnosis. Okay? Because my rapid diagnosis will give me the bug, it will give me my resistance pattern, and I'll be able to understand what to do within 6 hours. You understand? Now if I have the antibiotic answer in 6 hours, I am the most happiest person in the earth. Right? I am doing justice to my patient, isn't it? I am doing justice to my patient. Otherwise, I am waiting for 2 days to get my cultures done. Got the point? So we may start any of these antibiotics, but we have to be very, very careful. If this patient is affording, we would want to do RDTs, rapid diagnostic testings. You want to do that. Clear on this? Clear? Right. So now the next question is, we've decided our atypical, we've decided our gram-negative power. We have decided. Now all of us sitting in this room understand what is going on in my mind. You all understand what is going on in my mind now, right? Now the next question that comes is, do I now add gram-positive cover like Vanco, teicoplanin, lemonadifloxacin? You know, do I do that for Staph aureus? No, Streptococcus gets covered. For Staph aureus, this may not be a good combination. The question comes is, do I start my MRSA cover? Ashok, what is your thinking? We have a severe, this is now community acquired pneumonia. Our patient was Lakshmi, who was quite old. She was she has come in with respiratory tract infection, and then she had to come into the ICU. And she was reasonably sick. Question is, will I start this patient on teicoplanin, and why? If you want to or if you don't want to. How? What would be your strategy? Just for my knowledge. You don't know.
So we don't want to start MRSA.
So you say you don't want to start. And what would be the reason that you don't want to start MRSA? What would be the reason? This is not an exam. What do you feel? I did the chest X-ray. It shows a pneumonia. Ultrasound shows it's pneumonia. It's a big pneumonia.
If the patient is immunocompromised, like on
So
dialysis,
she's diabetes. She's creatinine was 1.8. She classically is not having great immunity.
so then you should start immunocompromised.
You should start MRSA cover. So that means to say every patient that comes in the ICU should be like this only. Have you seen a young patient coming normally to your ICU with breathlessness, with pneumonia? That means every patient of yours that you admit in the ICU will probably get. So this is the problem. So how do you tackle this? So understand the formula that I'm giving. Alright, understand the formula that I'm giving. So first of all, as I told you from the start of the lecture, when you don't know what to do, what do we refer to? Guidelines. So let's see what the guidelines is. Okay, let's go to the guidelines first. So this is the IDSA guideline. Okay, this is the IDSA guideline. So clinical practice guidelines by the Infectious Disease Society of America for the treatment of MRSA infections in adult and children. What does this guideline say? This guideline says, pending sputum culture or blood culture, every patient in the ICU requires a MRSA cover. Written here. For hospitalized patients with severe community-acquired pneumonia, defined by any one of the following, that means requirement for intensive care unit, anyone. That the ICU we are talking about ICU patients. ICU patient will require MRSAs recommended. Empirical therapy for MRSAs.
Every patient.
This is what the guidelines says. What's the guideline? IDSA, Infectious Disease Society of America guidelines. Now let me go to the same guideline in the same year for pneumonia. Okay, for pneumonia. Okay. So from where the evidence is coming? The evidence is actually coming from opinions. There are a couple of studies. They come from opinions. They are not studies. They are opinions. Right? Tomorrow I can stand up and say this is my opinion, this is not right. But this is evidence from opinion. So let us look at the IDSA guideline that actually comes from community acquired pneumonia. Okay, now look what it says. Same IDSA, okay, this is the same IDSA. And what does it say? It's supposed to be used for a specific group of individuals who have necrotizing or cavitatory pneumonia. Abhi, same society, एक community acquired pneumonia guideline, एक MRSA guideline, एक बोलता है हर ICU patient को दो, दूसरा बोलता है एक specific group देखो, जिसमें इसको necrotizing to cavitatory pneumonia उसको ही दो. So see how difficult it is to actually look at a guideline now. कंसेप्ट समझ में आ रहा है? एक ही गाइडलाइन कमिटी IDSA, दो different guidelines which comes from the same organism, and they give two different pictures. That's why you need to understand what is to be done yourself. That's why in guidelines, if you read what is written, this is what is written in guidelines. What is written? It is important to realize that guidelines cannot always account for individual variation among patients. They are not intended to supplant physical judgment, physician judgment with respect to particular patients or special clinical situations. Adherence to these guidelines should be voluntary. If you want to listen to this guideline, you do it. With the ultimate determination regarding their application made by the physician. Clearly बता रहे तुमको करना तो तुम करो. It is not telling you this is the right thing to be done. It is just saying maybe we can do this. That is why what you need to do when you read a guideline, understand everything around it. Then formulate your own protocol. And that is what we do in our ICU. In our ICU, I have the guideline in my mind, but I formulate a protocol based on a guideline, based on expert opinion, and then come to a complete formula. This is what we are going to do. It's not based on just a guideline. Never put your theory or therapy based on just a guideline. That is why to understand the guideline, you need to understand pathophysiology. You need to understand other evidences. So just reading a guideline for you now is perfect. But you are in a continuing education phase where you should not just read a guideline. You should keep on reading more. Are you understanding? Otherwise you'll be stuck with the guideline. If you follow the IDSA first guideline, Mrsa will give Mrsa government to all your patients. If you follow the next guideline, you will wait for the specific group of individuals. What do you do at the end of the day? So what do you do away? So for example, you have a patient, our own patient, 70-year-old diabetic patient with dementia, our Lakshmi who came in with features of pneumonia. Will I give Mrsa? This is the question I asked her, isn't it? So she said I will give. You said because she said I will give. You said I will give. Because Hemant looked at the IDSA pneumonia, he said I will not give because he doesn't have specific diabetic pneumonia because you said alcohol or something. Good question. Yes, no, maybe okay. Now, what I did, I set up cultures, gram strain. Gram positive cocaine cluster. This is what happens in the ICU, right? This is gram positive. Now, what do you give Mrsa? Question that comes in. What do you do, Hemant? ग्राम स्टेन तो 6 घंटे में आता है, 2 घंटे में आता है ग्राम स्टेन. 2 घंटे में तुमने ग्राम स्टेन भेजा, ग्राम पॉजिटिव कोकाइन क्लस्टर्स. अभी देगा कि नहीं देगा, दे सकते तो कोई भी कर सकता है. You give or no, yes or no, not in the middle. वो तो नहीं है. हम लोग ने patient has come in, our Lakshmi came in, he sent a gram stain. The gram stain came out to be gram positive clusters, cocaine clusters. वो स्टैप जैसा हो गया ना. Give, so you would give, right? Anybody would not want to give it? Anybody who doesn't want to give? Alright, now you have gone ahead and on day 3 you have seen non-necrotizing, non-cavitatory pneumonia. If this was necrotizing cavitatory, I would say very good. Spot on. Now you did a CT or an X-ray. And if for non-cavitatory, non-necrotizing pneumonia, but Mrsa is growing for some reason. He is clinically improving. How we can do? Usual case. I am telling you, usual case. यही होगा usually. Usually यही होगा. You are understanding? अभी question क्या करें? Mrsa का क्या करें? Would you still give episode? Would you not give? Would you cut it off? Patient is clinically improving. एक दिन में थोड़ी change होने वाला. ये तो एक दिन में change होगा. So let's go to what to do. Okay, let's go to what to do. So now you understand what I do. So that you understand what I am doing in the ICU. I am doing this for ages. I wanted to follow what I am doing in ages because this is my formula which I have found out from my understanding of the guidelines. So I wanted to understand as a protocol what you are supposed to do. Okay, don't do it blindly. Understand what I am doing. Okay, you understood why it is so difficult to create a guideline and why it is so difficult to actually follow something. That is why after synthesizing the evidence, I have come to a conclusion as to what we should be doing. So I will explain to you what we do. And we have to do it like this. Okay, what I am going to do is, I am going to look at few data and then come to a conclusion. This is what I am going to do. Now I am going to look at data and then tell you why I am doing that. Okay, so let's see the first data that we have. This is 2016. Elderly. This is in the gerontology. Gerontology means old people journal. So in that journal, they actually looked at a good number of 90 plus participations in which they actually figured out whether the Mrsa was actually pathological or just growing. Tomorrow if I culture from America now, Mrsa don't even tissue and make a sit over here. It may grow. Right? It may grow. But you don't have anything. So that is not true pathogen. They are colonized. Many patients in the ICU are colonized. by various organisms. But whether they are pathogenic, that is the question you have to answer. So they did this study where they actually looked at all these patients, 93 patients. Okay, so I'll just do it up for you. So you had 93 patients. Okay, true MRSA pneumonia was in 16 only. That means they cultured the organism. They found MRSA coming from the pneumonia, just like our patient that we just now did. But the true pathogenicity was there only in 16 of the 93. This is an article that was done some years ago. Clear on this till now? Let's do another article. This is another article. Clinical impact of MRSA Staphylococcus aureus on bacterial pneumonia, cultivation of N16S ribosomal RNA gene analysis for oncolytic. What they did? They again looked at the same thing. True pathogen है कि just colonizer. So in this also, down there I'll repeat more than enough for you. Where is it gone? So what they found was 66.7% good number was MRSA and 33.3% was MRSA positive. So what do we understand? That MRSA can grow, but that may not be the cause of the pneumonia. That may not be something I want to add. It can grow, right? No, it can grow otherwise. So that's why it's a very tight road to walk when I'm actually looking at MRSA, because the sensitivity is very high for the diagnostic test. तुम करो तुमको मिल जाता है, बहुत जल्दी मिल जाता है स्टैफ. Very low incidence. Now we saw from these two studies, we saw that the incidence actually of pneumonia with MRSA is actually very, very low. So what is our question? To prescribe or not to prescribe? That's our question, isn't it? Because that's the big question that we have to answer. So what is the strategy that we will use? What is the strategy? So let's look at our strategy. Our strategy will have 5 points. Okay, there are 5 points in our strategy. So this is what I want you all to do when we have severe community acquired pneumonia that comes in. Okay? What is the strategy? The strategy will involve 5 points. And based on these 5 points, we will take a call what we are going to do. When we go to each of those 5 points one by one. We go to each of those 5 points one by one. So we start with the source code, which Niharika showed. Simple cheese, you open Medicare, you put source code, you get it. If you open Medicare on your I'm open Medicare, this is Medicare, you open Medicare, and what do I see here? I see source code somewhere here. Where is it? Down here. See there? MRSA patient pneumonia source code 2013. So if you open up Medicare, you get this. Okay, you open Medicare, you get it. Simple. It's very simple. Okay. Now what is this entire study? This entire study is a very large study. It was an analysis of 62 US hospitals. How did the Shore come? Which was Shore's code, Andrew Shore. I had actually applied for a fellowship with Andrew Shore a while ago. He had actually accepted me on a fellowship also, Andrew Shore. Okay, I didn't go there for different reasons, but I had a fellowship with Andrew Shore. So what did he do? Veteran Affairs, 62 US hospitals, all the samples he took together of MRSA who were pneumonia, and then he put them into a category. He put them into what इसको क्या है, इसको क्या है, इसको क्या है, ये इतना एज है, इसका डायबिटीज है, इसको ये है, इसको वो है, ऐसा पूरा क्लिनिकल डेमोग्राफिक्स उसको डाल दिया. So 72,000 some patients they looked at. How many? 72,000 some patients. That's the amount of patients he looked at. Okay, and he looked at those patients who were community acquired pneumonia and healthcare associated pneumonia. So he excluded this and looked at this. Okay, so when he did that, he found this criteria, which you see on MD Cal. On Cal, you see this criteria. You see this variables that are here: age less than 30, more than 79, prior healthcare exposure, which includes recent hospitalization for more than 2 days and within the last 90 days. Nursing home, hospitalized facility, prior therapy, antibiotic IV therapy within the last 30 days, severity of illness, ICU admission before the culture that we have sent, comorbid illnesses like dementia, cerebrovascular disease, female with diabetes. So if you put our patient in this, female, dementia, age, and ICU admission. So scores are high on our patient. That was there in the Lakshmi that I showed you. Okay. And what did they find out over here is, if you had a very low score, 0 to 1, the incidence is less than 10%. Incidence is less than, I'm not really worried. Less than 10% incidence. Right? So less than 10% incidence is what you're getting if the score is very low. If it is in the medium, I don't know what to do because it's 2030. remember this, whenever your incidence is more than 10%, you have to empirically cover it. Whenever your incidence is more than 10%, you may have to empirically cover it. You may have to. Okay, so if my ISO has a prevalence of 22% of MRSA, you have to cover MRSA. That's the thinking. Similarly here, you have more than 10%. I'm not very certain whether I should cover or not, but I'm certain that if my incidence is high, I have to cover it. Okay, I have to cover it. I have very high chance I have to cover it. Okay, very high chance I have to cover it. This is what I feel. Of course, people will say retrospective data है. इसको हर patient को निकाला नहीं इन्होंने. They were not evaluated for co-infections. This is people will talk about all these things because this is a big database that they looked at. It was not a prospective study per se. Okay, so what happened is the same score was actually taken up for a validation by the Veteran Affairs, which is a big hospital. Veteran Affairs. Okay, so in the Veteran Affairs, what they did, they actually looked at SHORE score. And the very next year, they published data that said that if you use the SHORE score, I'm able to stop my MRSA usage. So it is good for stopping. So if you have a low risk patient, I can improve identification of patients at high risk and at low risk and present to the hospital, and so I am able to reduce my MRSA coverage. जो low है उसको देने का. You are able to do that, and it helped these people very importantly. And then they use this again in another study. Okay, and there again they found the same thing, that it helps spare MRSA therapy for only those patients who are likely to benefit. So now I have one criteria in the way I should do it. That is my SHORE criteria, because there are studies and there are validations. That are two validations that have actually said that maybe this is one of my starting point. I'm not going to use anything exclusively, but this is the guideline for me. I start thinking so let us know. Clear on this? Because as I told you, every antibiotic that I'm giving, I'm actually creating resistance if it's not required. How does it create resistance? Any idea? Niharika? How does it create resistance? If I say you are having a viral illness, and I today give you penicillin antibiotic, Ceftriaxone. Okay, I give Ceftriaxone for example, not penicillin, I give Ceftriaxone. How does it create resistance? तुम तो घर पे खा रहे हो. So, anyone, how does this antibiotic create resistance? You understand what I'm saying? मैं antibiotic ले रहे घर पे ले रहे क्या फर्क पड़ा? ले लो यार, कुछ नहीं होने वाला. Mutation मेरे घर पे हो रहा है ना? Resistance किधर हो रहा है? What happens usually? What happens usually is you take an antibiotic. If it is not required, where will the antibiotic go? It is because the body is not taking, not required. Body is very intelligent. नहीं चाहिए. क्या करेगा? It will pass it into the urine. Where will this urine go? Into the groundwater. Then where will the groundwater go? Into the farms. What will happen over there? It will be given to the vegetables. It will be given to the poultry. It will be given to all these places. From there it comes to resistance. You understand? And then that circulates in the same environment. Are you understanding? This is what occurs. So groundwater pollution occurs. And that causes biggest problem. That's why animal industry is the worst industry. Why is it the worst industry? Have you any time gone to Crawford Market? Crawford Market मालूम है किधर है? हाँ, CST के बाजू में Crawford Market गया अंदर market में गया. Let me tell you a story about this. Okay, so some 4-5 years ago, I decided, I want to buy a bird. Father okay, I want to buy a bird. पता नहीं कैसे मैं I want to buy a bird. So I don't know. Sometimes it just comes to mind. Actually, क्या हो गया था? मेरा एक uncle था who used to own parakeets. My uncle used to own parakeets, African parakeets. He shifted to Kerala. So when he shifted to Kerala, उसके पास उसने वो bird लेके गया, लेकिन वो केज छोड़ दिया. तो मेरे घर पे आके मेरे को बोला कि संजीत वो केज तो रख ले. अब मेरा घर थोड़ा बड़ा है तो मैं बोला ठीक है, कीप द केज, रखेंगे. अंकल रखता था मैं भी रखूंगा. और तो मैं बोला ठीक है, केज लेके आया घर पे, बड़ा केज. अभी उसमें मेरे को डालना था एक बर्ड. तो मैं पूछा कहाँ से तुम्हें बर्ड? अंकल बोला क्रॉफर्ड मार्केट जाओ, उधर मिल जाएगा. मैं गया क्रॉफर्ड मार्केट. So I went to Crawford Market and I got a very beautiful bird of price special. मस्त था वो एकदम. उसको देख के ऐसा लगा वाओ क्या बर्ड है ये. है ना ऐसा उसको देख कैसा लगा but they said we will take care of the bird more better than the people over there. Those people have cut their wings and this and what all they have done there. So I told him कि देखो ये bird I was stunned at the cost 75,000 rupees. I was stunned 75,000 rupees for a bird, you know. So I was, first of all I was stunned at that. मैं बोला कि 75,000 मैं खर्चा नहीं करूँगा 75,000 2-3 हज़ार रुपए का रहेगा सारा 75,000 रुपये सोचा ही नहीं मैंने. I never thought it would be 75,000 rupees. So I actually I bought that I went to buy that bird. So I told him ठीक है तो if I have to take this bird EMI कुछ है क्या ये सब you know ऐसा होता है. So उसके बीच में my child started crying. लेना ही है मेरे को. 75,000 खर्चा तो करने का होगा. So then I asked him ठीक है तो क्या करना पड़ेगा. तो उसने बोला सर मैं आपको बर्ड डिलीवर कर दूँ तो घर पे हाँ और उसके साथ में ये भी entire strip of antibiotics. पूछा ये क्या है हाँ एंटीबायोटिक्स भी दे रहे हैं मुझे स्पाइरामाइसिन एंड ऑल दीस थिंग्स तो पूछा यार ये क्या है ये क्यों दे रहे हैं मेरे को. सो दैट्स वेयर I understood that you know they give these birds antibiotics to keep them healthy all the time prophylactic. So then I asked him ये एंटीबायोटिक क्यों दिया मेरे को. ये बिकॉज कि आपको ना बर्ड जिंदा रखना है बहुत महंगा है हाँ तो ये आपको देना है डॉक्टर्स बट दिस इज व्हाट दे डूइंग देयर. सो देन ही टोल्ड मी आपने जितना भी चिकन आई गॉट एंग्री ऐसा ये क्या है ऐसे क्यों दे रहे तुम लोग हाँ तो इसे नहीं पूरा चिकन इंडस्ट्री पूरा पोल्ट्री इंडस्ट्री में दिस इज व्हाट वर्क्स. सो इफ यू गो टू एनी ऑफ द पोल्ट्रीज एनी ऑफ द चिकन ब्रॉयलर्स दैट यू ईट नाइस पिग दे आर गिवन एंटीबायोटिक्स ऑल द टाइम हाँ they give antibiotics all the time and where does that go ground water where does it go into your body. That's how resistance increases. So I was I did a television interview on this and I wrote an article in the paper that this is what I got in Times of India Mag. If you put Dr. Sanjay bird and animal husbandry, you'll get that. Okay, so I wrote a lot of articles, but that's how the industry is. You understand? That's how resistance comes in. You understand? That's how resistance comes in. So that's about why you should not give an antibiotic that is not required. So that's why when somebody comes and says I have Ayurvedic asthma, I feel like giving one time rap on his face. Because what would happen? Next day my child will have a problem, he will not get cured now. Are you understanding? And then let me tell you one more story on this. So we had a CEO here. Whose daughter had a UTI. So he admitted this patient onto the ward because he had a UTI. Patient was not doing very well, fever and small baby. Hardly 8 years old, 9 years old, who came in here. Our own CEO's child. So one day they put the patient on simple ceftriaxone, which is the ward. 4 days patient didn't do well. Patient had fever, patient kept having fever. Now who will change for an 8-year-old ceftriaxone, which is a simple drug which is brought for that child. Child को कुछ नहीं मिला है, पूरी जिंदगी में कुछ नहीं मिला है. And they're giving him ceftriaxone. Giving us ceftriaxone which is actually brought for the child. If you look at the child को antibiotic दो देते नहीं हम, right? Then what we did, he told me Sanjay please come and have a look. I was not involved in the case till that time. It was the pediatric case, so I was not involved. So I told you know what, if it's not healed in the last 3-4 days, there is something really wrong. We need to figure out. So ultrasound किया, कुछ नहीं मिला. I then took the urine and sent it for rapid diagnostics. And I found carbapenem-resistant Enterobacteriaceae. And this child, who basically came with the UTI, we had to put her on polymyxin, colistin, and aminoglycoside. Imagine a patient who comes with UTI gets colistin and aminoglycoside. This is the near future that we are staring at. And that's the reason that antibiotic you should be able to understand how to give, whether to give or not to give. That is the reason I'm telling you this. It's a fact. This happened here in this hospital. All right. And she was here for 14 days after that because she had a CRE. It was not healing, and colistin doesn't really work very well in the urinary tract. You understand? So this is the problem. So now that is why you must understand the shore score. At least by the shore score, you will come to a conclusion that I don't need to blast this patient with an Mrsa cover. Have some idea that I may not require Mrsa. Now I need to go ahead on this. Let's go ahead. So there are 2 other things that I always tell you about. I tell you throat swab is good. So you are not understanding why I am telling you that. Because I want to go towards my diagnosis further. I want to do a throat swab and I want to do a sputum gram stain. We did it for that other patient, but we did a throat swab. So sputum gram stain, very simple thing. When they looked at it, they found out the diagnostic utility in pneumonia is very, very good. So at least you can send it, you can gram positive cocaine clusters. I'll start thinking at least. कि है, अगर है ही नहीं, there is no problem. अगर है ही नहीं, तो बोलेगा अरे नहीं ये तो gram negative है, gram positive नहीं. समझ में आ रहा है? So I'll be again be able to tell him that okay, I don't need to do further. लेकिन हो सकता है इसमें. अगर so when you say that is why a sputum sample has to be done very well. That is why sputum sample cannot be just a उसने उधर दे दिया. It has to be coming from inside. Nicely physiotherapy करके you should spend time to get an adequate sputum sample that is showing one organism. If it is showing multiple, it is again wrong. It has to be a characteristic high quality sample, and that is why I insist that you do this, you do that, put him down. You just can't go RI base there, just put him base there. It will not come. We need a good sample. Clear on this? Clear? Now we need a good sputum sample. So sputum gram stain, and the next is the throat swab. Now what is this throat swab? What we found from here? Look at this. This is non-intubated patients and these are intubated patients. Surveillance of trachea or throat for MRSA is more sensitive than nasal surveillance. You know, we have patients coming from out of the hospital. We said nasal swab for MRSA. Now compared to the nasal swab for MRSA, all patients, you know, are you aware of this? When a patient comes from another ICU or another hospital, we said nasal swab. Okay, we said nasal swab. Okay, for understanding MRSA. But the throat swab is much more better in intensive care. So in the hospital, nasal swab is nasal PCR is fine, nasal swab is fine. But in the ICU, the throat swab is much better. What is it showing here? Non-intubation patients, intubated patients, they are getting positivity in throat swab, not in skin, not in rectum, and not in nasal as much as throat swab. It's obvious, no? If I am going to get a pneumonia, my tract is going to be this only, no? If my tract is going to be this, it is going to be my throat. Nose is something we keep cleaning. So it's the throat that don't clean. So it's the throat that comes in. It has to go from here. When I'm doing a surveillance, I'm not doing it for finding pneumonia. When I'm doing a surveillance, I'm just trying to figure out इसको आइसोलेट करूँ कि नहीं करूँ. दूसरा हॉस्पिटल स्किन में इधर है उधर है कुछ. समझ में आ रहा है? But when I'm diagnosing pneumonia, the pneumonia comes from where? Comes like this. It has to come from there. So it is logical to say that a throat swab will actually work better than a nasal swab. Clear on this? That's where the throat swab becomes. That's why I commented throat swab is like why do I tell that? Because I know my pickup rate of throat swab will be much higher. For example, I get a nasal PCR, I get a sputum gram stain, I get a throat swab both being negative, and my short score is less. What do? I don't need an MRSA where it looks like. You know, it doesn't look like I need an MRSA cover. Other way around, I got my short score that is high. I got gram stain with clusters of very good quality sample sputum that says gram positive cocaine clusters. I got a throat swab getting gram positive. Now I think what? Oh, this is one of those patients that are required to start at an MRSA cover. And that's why when you see these curves, so this is the nasal. So nasal, the sensitivity is very low. When you go towards this part, in any curve that looks like this, in a diagnostic curve that looks like this, any diagnostic curve that looks like this, the more the curve goes towards this part, the more it is sensitive to pick up. This will be a standard curve. This is 1 minus sensitive. This curve you see in many diagnostic algorithms. Okay, so this is my diagnostic algorithm. In the diagnostic algorithm, if I look at all four sides, this is where I am. If I look at throat and trachea, this is where I am. I am closer to the 100 mark compared to the nasal swab, which is down here. This is a statistic finding that you must see. If you see troponin, you'll see this. Troponin will be something like this. Troponin will be like this. Troponin, because it's the most highest sensitive indicator. So that will be like this. That curve will come like this. I'm just telling you for an idea of what I'm explaining to you. This is called ROC curves. Okay, they call it ROC curves. So this is how we interpret a diagnostic test. When you do a diagnostic test, you will see these curves. You must be able to interpret them. So now what we will, we are going to look at short score. We are going to look at sputum swab. So now we finish short score, throat score, sputum, gram stain. Then the other two things are something that I feel is not very relevant. But say if somebody sends me, I'm okay. Why? Because I know a procalcitonin I will probably not be elevated if you have atypical pneumonia, Legionella, viral pneumonias, atelectasis, aspiration pneumonitis. It may not get elevated. So if somebody, I don't want to send it, but if somebody is sending it, I am confident that okay, वो negative अगर आ गया तो probably I can kind of rule out. MRSA. समझ में आ रहा है? So I am not saying that send procalcitone. Procalcitone actually is a great biomarker for de-escalation of antibiotics and not for escalation of antibiotics. What is it good for? And not for escalation. So it is good for de-escalation of antibiotics and not for escalation of antibiotics. Clear? So, but if somebody sends it, okay, negative आना चाहिए. अगर वो negative आ गया, then I can kind of say probably a staph नहीं है. Somewhere because Staphylococcus aureus being a very difficult organism, a bacteria, it will cause the procalcitonin to go up, may cause the procalcitonin to go up. But if it's negative, it's a rule out. Again, it's a rule out. So somebody said, no, let him send. Though we know that we will not send it because we know it's not something that I want to do in these cases. We don't want to send it. It's expensive. That's the reason I don't want to send it. Okay. And at the end of the day, as the first IDSA guideline said, what you cannot replace? That's where we all work. We have got guidelines, we have got different ways to do stuff, okay? But at the end of the day, it's our clinical judgment that will come only with training, practice, and continuous working in the ICU. It will always not come. That clinical judgment will never come. That is why if I want to use in our patients, what do? I got a quick strategy. I evaluate the MRSA score, that is a short score. If it is 0 to 1, I will think of no coverage. If it is 6 to 10, probably I may start ICU. Probably I may start in the ICU. If it's anywhere between that, I will send a gram stain throat culture. Maybe if somebody wants to send it, I'll send it. But throat stain and gram culture is what I'll send. And then I will actually start MRSA cover or rule it out or not give advice. Simple. It makes it simple now. At least now, at the end of the entire, we started by saying that the IDSA guideline doesn't know what it's saying because they had two different guidelines for the same particular organism. And now we have come to a conclusion as to why we have to do a certain thing because of the synthesis of evidence that we've just now done. You understand? Huh? So now, to end the entire thing, completely went through everything. Okay, what is the important thing? We should know your local antibiotic. We will probably start a PLI carbapenem or a carbapenem. One of the two we just now discussed that. Streptococcus or Pneumonia or carbapenem. We will probably give all patients a macrolide. We discussed that why we should do that. We will either add an MRSA cover, based on all the criteria that I mentioned. Okay, and then only our patient we can kind of our patient will do it. This is the antibiotic of choice. Antibiotic that if I have to start with for the that is of the severe variety. We are not talking of everybody that is at home or your ward. We are talking of which ICU. Got it? So any questions here? Any questions?
So many times the macrolides, the antibiotics also registered that if you started,
Why are we giving azithromycin?
I don't know. But the
Immunomodulator, giving something, it does something, it kind of reduces the mortality, irrespective of whether it is that is why I'm giving it for, it is said you 3 days also is enough. You understand? Like your 3 days also is enough. You don't really require to give it for 7 days or 10 days or 5 days or something. You understand? You are giving it because of another effect only. We see from studies that it is actually dropping the